Did you know that the most common childhood disease is caries? It is 5 times more common than asthma, 4 times more common than early childhood obesity, and 20 times more common than diabetes. And like caries, there are other dental problems too, like gingival inflammation, white spots, tooth loss, bone loss, etc. It's common knowledge that one thing leads to the other, and this sequence is set on fire by dental plaque. Now, the majority of dentistry is involved in fighting against it, but orthodontics can sometimes play a spoilsport. Orthodontics, in fact, creates a typical environment which appears to promote plaque retention, and also makes it perhaps impossible for someone to regularly brush all the areas of their teeth. Nevertheless, over the years, newer appliances like self-ligating brackets and clear aligners have minimized the hardware on teeth, and have arguably gone on to claim that they provide superior hygiene than their predecessors. But hey, claims are good, but what about the evidence?
The most reliable evidence would be obviously coming out from a meta-analysis. But for that to happen, you need more robust studies like randomized clinical trials. And what's happening right now is that most of the studies out there have either small sample sizes or there's a bias built in them, a lot of confounding variables, which is anyways tough to control. So at the end, the evidence that you're going to get from it is going to be only of moderate level.
In 2011, Dr. Upadhyay at the University of Connecticut Health Center, along with his collaborators, started working toward answering this question: which orthodontic appliance is best for oral hygiene? For this, they wanted to evaluate the 3 most common appliances: clear aligners, self-ligating brackets, and conventional brackets. They were evaluated at pre-treatment, 9 months into treatment, and at 18 months into treatment. The following periodontal parameters were evaluated: plaque index, gingival index, and periodontal bleeding index. Each was graded into 4 distinct categories: 0 for healthy, 1 for mild, 2 for moderate, and 3 or greater for severe. Patients were randomized with some very strict inclusion and exclusion criteria.
The criteria was set in such a way so that one appliance won't have any kind of foreseeable advantage over the other. The flip was that because the appliances were so varied, patients developed strong preferences, and therefore eligible patients dropped out or had to be excluded.
First of all, it was a long term, not just 4 weeks, 10 weeks, 3 months, but a solid 18-month study. And then obviously the second point is much more important, which is the randomization, which is a rare entity in orthodontics. And especially in this study, it's very tough to do because one of our groups are clear aligners.
The research took 4 years to complete, involving over 80 patients and 5 investigators. The amount of data generated was enormous.
So our data is essentially longitudinal data, but we didn't feel longitudinal data. Typically, the GE models and generalized linear mix effects model, because the change in the outcome is not linear across the time, and that means we need to use extra parameters to model the time trend.
The results were put together and analyzed. No clinically or statistically significant difference was found in any of the indices, PI, GI, or PBI, between the different appliances after 18 months of treatment. Now, to some, even before starting the study, it appeared very obvious that a device that you can wear and remove should give better hygiene. But how do we explain this?
Now, if you look at the results at the 9-month interval, the periodontal scores are increasing, going up, and there we see a significant difference. However, by the 18-month time point, they kind of come together, and there's no difference amongst them. So that's pretty interesting.
So the question to ask is, why this increase and then decrease, especially for the fixed appliance groups?
Hawthorne effect.
Hawthorne effect.
Hawthorne effect might have a role to play out here.
The Hawthorne effect was first observed in 1925 at the Hawthorne Works in Cicero, Illinois. It was originally interpreted by Elton Maya. Sometimes also called as the observer effect, it basically means individuals may change their behavior due to the attention they are receiving from researchers.
So the participants exactly knew why they were in the study, so there was no blinding there. So when the feedback was given at the 9-month interval about the worsening hygiene in those set of patients, an improvement was bound to happen.
You tend to become better with hygiene as you see an improvement in the appearance of your teeth. Many of our patients were very young teenagers when they signed up and matured as we went along, thereby showing improvement.
If you're doing an RCT and you're asking the right questions, I believe that there will be a high likelihood of getting the results that won't be significant among different groups. In a good research, it is very tough to show clinically significant results.
I don't think just the type of appliance, or maybe in general the orthodontic treatment, has a massive effect on hygiene. I mean, there is some effect, but not as compared to these other big factors like diet, nutrition, socioeconomic status, maybe fluoride exposure, quality and quantity of saliva, immune factors, and so on and so forth. There could have been some effect of the appliance, but whatever measurements we got, it was basically from 0 to maybe 1+.
And more evidence is coming out in this regard. A recent meta-analysis has shown that orthodontic treatment has no effect on periodontal attachment. In another study on caries, the authors concluded that fixed orthodontic appliances significantly decrease caries risk. However, as always, more evidence is welcome. Thank you for watching.